Well, firstly, introduce myself and what I'm trying to develop within the ICB, Integrated Care System across Northeast and North Cumbria. So to give you a flavor of where we're going, as you're probably all aware, the Integrated Care System, well, the CCGs, Clinical Commissioning Groups, ceased to be at the end of June last year, and a new entity emerged called the Integrated Care Board. It is something that's been in the works for a number of years. It was a partnership of CCGs before for a number of years, and then for a couple of years, it's been working toward developing the statutory body called the ICB. And across our region, across Northeast and North Cumbria, the ICB has 4 integrated care partnerships that are slowly being developed. So the northern region, which includes Northumberland and Newcastle Gateshead, and then Cumbria on its own. And then we have the Tees Valley and the central area, which includes Durham and Sunderland and south of Tyne. Um, so basically, this organization is now responsible for commissioning, but our ICB, there's 40 plus ICBs across the whole of England now, and increasingly, NHS England is devolving a lot of responsibilities through to the ICBs, and ours is the only ICB amongst the 40 odd ICBs which has actually a dedicated research and innovation function at the executive level, which is quite unique. So we're quite fortunate in that, but we're also figuring out how it will work. So it's my role to help make that happen. And so I sit on the executive team in the ICB and work very closely with the chief medical officer, the chief strategy officer, our director of digital, to start to figure out how we can really foster a culture of research and innovation. Within the ICB, we also have a number of committees. One of them, which is very relevant to this group, is our quality and safety committee, which has sight of performance data from across the region, and we continuously find opportunities for improvement within that, also opportunities for innovation and research and evaluation. So I'll just quickly whiz through some slides. So I've only been in post for the last 6, 7 months, and been going through a process where starting to engage with all the different stakeholders relating to research and innovation across the region. So the ICS has fundamentally 4 aims, is to improve the health of the population and reduce health inequalities, improve patient experience and outcomes, and also, I would say, staff experience and well-being, and then making the best use of the limited resources we get from NHS England. We are the largest ICS in the country, so we get a fair chunk of resources, but there's always never enough, as we often know. So what is the integrated care system? We see ourselves as effectively a convener. We bring together, there's fantastic pockets of innovation and research happening all across the region. And our role is effectively to make the sum of their parts bigger. And so trying to convene, choreograph opportunities for collaboration, create systems which will enable us to co-produce with our staff and patients alike, and connecting people to develop collaborations where they don't currently exist, building capacity, helping to clarify roles as they emerge. And this is something that's an ongoing process because we're still figuring out what our role is as more and more responsibilities are devolved from NHS England through to the ICBs, and then helping to mentor and steer change and building various communities of practice as we go along. In terms of our research and innovation ambitions, we uh, our main ambition is to support the Northeast and North Cumbria-based research and innovation infrastructures and delivery teams who are already doing some fantastic innovation work to continue to thrive and grow. Develop systems which foster research and innovation initiatives directly relevant to our unmet needs across the system. So identifying those unmet needs and prioritizing them, but which are pragmatic and action oriented. Sometimes research can become very academic, and our ambition is to steer research from across our fantastic academic partners into very much, impact focus. So ensuring that that research doesn't take 16 years, as they typically say, from idea to actually wide adoption in the health and care system, but to reduce that the length of that pipeline somewhat. So trying to make research a lot more impact focus, and nurture more person-centered approaches to needs identification, research, innovation, service design, etc., and improving our understanding of the lived experience of patients, staff, and the communities that they're situated in. And as our learning and improvement community develops, and I know a lot of people here have been involved in our learning systems, you're probably aware that the ICS is investing quite heavily in developing a learning and improvement system and community across the whole of the region, trying to embed that into these learning loops that will help spread learnings as quickly as we can across the whole system, and then collaborate with our academic partners to evaluate good, some of the best practices that emerge as a result. And one of the things that we're really keen to develop, and from the top down, from our chief executive, we've had this permission effectively to create a positive error culture where we're not shying away from failures, but sharing and learning from those failures. So trying to create a culture where we can quickly learn from mistakes. So the ICB came into force through the Health and Care Act. And within the Health and Care Act, there's specific sections which mention a duty to promote innovation and a duty to promote research. And so within research, there's a number of areas that we need to develop as an ICB, including a dedicated research office or team which would provide support for research. And it also says to articulate local research needs when assessing local needs. So back in November, we brought together a number of key stakeholders from across the region, from the 6 universities across our region, many of the NIHR infrastructures that are situated here, colleagues from Health Education England, research and innovation directors from many of the major acute trusts. 4 councils were present. We out of the 14, which is probably not very representative. Hopefully, in future meetings, we'll manage to get more representation. We had, although, 2 health determinant research collaboratives, voluntary sector organizations, and representatives from primary care, etc., to come together, and we held a really hands-on workshop to understand where some of the gaps are in collaboration and where some linkages can also be made with, for example, improvement, quality improvement, etc. And many ideas were discussed, many gaps were identified. We put these together into what's turning out to be like a research and innovation strategy document for our ICB. And these are some of the key, I guess, emergent themes that came out from that session. So, tackling inequalities and wider determinants of health, understanding our regional expertise and making the most of them, shared learning and data, funding and investment, workforce resource capacity building, and opportunities for collaboration, patient engagement and outcomes, etc. And within each of these, we've started to distill some of the common thinking from across the teams that we and some key ideas are emerging, like developing a seed fund for innovation and improvement, having dedicated teams to support funding applications, and investing in innovative roles to bridge the gap between different sectors, such as, ambulance services and social care, etc. I won't go into each and every one of these, or I'll go well past my time, but just to give you a flavor of some of the ideas which emerged. We also, in parallel, you might have seen, have published a strategy for the ICB overall. This isn't the research and innovation strategy is still under development, but this is an overarching strategy for the system. And within that, there's some mention of innovation and research and the learning and improvement community as well. And some of the key points there are, again, involving service users and staff in identifying unmet needs, making use of data, sharing it more widely, and research evidence and insights, and supporting frontline staff and industry innovators, drive adoption of new solutions more widely, invest in innovation, develop more socially focused research opportunities, and then working with our academic health science network. So within our integrated care system, and specifically within the team that I'm leading, which is a very small team at the moment, so I beg, borrow, and steal from regional partners. And two key partners in the delivery of a lot of the work that our directorate will have are the Academic Health Science Network around innovation, and then the NEX, which is the North East Commissioning Support Unit, and specifically within that, there's a research and evidence team. So those two teams are key delivery partners for us. So from that whole exercise in November, we've started to develop a program of work. This is still a work in progress, but there's some key themes emerging. So fostering a culture of innovation, nurturing collaboration in innovation and research, and then facilitating communication and shared learning. And and there's a number of particular work streams within each of these, as you can see, emerging. So developing some quarterly place-based workshops, discovery workshops where we pick an area of improvement or an area, a big challenge, bring together the key stakeholders from that region and have a very person-centered design kind of approach to running a workshop. I really understanding the context of that need in depth, and then trying to find solutions to that need. We're also developing a program where we'll have opportunities for an innovation seed fund. So as some good ideas emerge from these workshops, to maybe fund a small amount, put a small amount of investment behind an idea to help try it out, and maybe pilot something on a small scale. If it fails, that's fine, capture the learnings from it. If it succeeds, then find further funding to scale it up, or commission the idea. We're also looking at developing some themed hackathons, particularly very interested around data, and then coordinating student internships across the region. We've got 6 universities here, and each of them have, our next generation of workforce being nurtured there, that we'd like to get them into the system as early as possible and work on some innovative and improvement projects as well. So I think I'm probably running out of my time, but very quickly, the research and evidence team in Northeast and North Cumbria is, as I mentioned, a key delivery arm as well, and do a lot of work to support particularly evidence-led commissioning, and are linked into areas such as library services across the region and Health Education England to capture and put together evidence from literature as well as grey literature to support decision making, um, and have a number of programs around knowledge implementation and mobilization that they can help all of our partners across the region. So we're still in the process of building partnerships with this vast network of incredible resources and assets that we have across the region, and hopefully starting to make some sense where they fit across this picture. As you can see, is what the academic health sciences building with us, what they call a innovation pathway, starting from initial idea and developing it through to something that could be adopted and spread across the system. And across that pathway, many of these different assets and stakeholders have play a role, sometimes have multiple parts of the pathway. And over time, we're developing an interactive map which will be available both on the Academic Health Science website as well as the ICB website, where multiple organizations can click on and find out what each other are doing and how they can potentially collaborate. Already, the NIHR infrastructures across the region are starting to develop this where they fit along this pathway. I'll stop sharing my screen now. So I was asked to talk a bit about how innovation and improvement, come together. And it's a question that we ask ourselves almost every day. And as I mentioned, within the ICB, I sit on a number of committees, including the Quality Committee, and there we have sight of, areas of improvement across the whole system. We're also very closely linked to, working in hand with the learning and improvement community. And within that learning improvement community, one of the key resources that we're looking to develop is a platform which will enable this learning and improvement community to communicate more quickly with each other and share learnings around improvement initiatives across the patch. But within that, there may be opportunities for doing some things very differently. You might find that you're constantly on a journey of improvement, but then at some stage you might start to think that maybe there's a completely different way of doing this rather than iteratively, changing, bringing changes. So that's where we, I guess, try to. It is a little bit of a gray area. Where does improvement end and innovation begin? But I guess we sometimes look at innovation as being, I guess, a leap in change, or a very different way of doing something. But it's not always that clear cut. Sometimes, improvements can be quite a step change in how you're doing work. And but I think underpinning a lot of that is evaluation. So we're trying to build a culture of evaluation, and that team from Next is pivotal in helping us to start to create a regular program of evaluation around innovation as we introduce new innovation, initially on a small scale, but then after, proving its worth, hopefully scaling it up as quickly as possible. So I think my 20 minutes are up, and but thank you for giving me this opportunity to connect with you.
Brilliant. Thank you so much, Aejaz. Has anybody got any questions at all for Aejaz? I've got one, Aejaz. So
Mhm.
you mentioned the Innovation Seed Fund then. When do you think that might be available for people?
So we're aiming from the new financial year,
Okay.
from April for it to start. We're still debating how we should design this. Should we
Mhm.
design it
Mhm.
specifically? One, thought is to design it in line with key areas of priority for
Okay.
the ICS
Mhm.
that are current. So, for example, discharge is
Yeah.
a big area of priority at the moment. And if there's some, and we're looking at, I think on March 9th, and I think Suzanne is involved in a
Mhm.
workshop that this is an initial workshop that we've got on March 9th, where we're looking at discharge processes and thinking about opportunities for improvement as well as innovation across the full pathway, from acute all the way through to
Mm.
the social care sector. And there may be opportunities there to, if there's some innovative new idea that emerges, that could be a first
Mm. Mm.
place where we invest some seed funding behind. So there's two schools of thought. Either we have like a rolling approach to it, or we have every quarter we have a call linked to a particular priority at that quarter. So we're still in the process of deciding which way to go
Yeah.
with that. At the moment, I mean, it'll start off relatively small, but it's not huge amounts of money. It's like we've
Mhm.
been
Mhm.
in that workshop that we had in November. People said that there's often funding to be found for bigger pots of money, like 100K,
Yeah.
150K and above. It's often the really small pots of money, like for like 5,000 to 15
Mm.
to 20, where you want to try out something on a small scale, prove concept, and then you've got that evidence to show that to apply for the bigger pots of money afterwards. So this is basically geared towards those
Mhm.
smaller kind of ideas that that are we could that could fail fast, and if they don't work, that's fine. We haven't
Yeah.
lost a huge amount of investment in
Yeah.
trying it out.
Yeah, and as you said, it's the learning that comes from it, isn't it? At the end of the day, even if it doesn't go quite right, it's why did that not go quite right, and how can we learn
Yeah.
from that? So yeah, brilliant. We've had a question from David in the chat. He's asked, how do we find out more about the collaborative work around data informed innovations?
Mhm. So this is a work in progress. You might have heard of something called a secure data environment, where we've been working with Next, their data teams. It used to previously be called Trusted Research and Evaluation um, Environments, and it links back to work that's been done over a number of years with the Great North Care Record, trying to integrate a lot of multiple data sources, and where we've been successful recently to receive some funding from NHS England to start to develop this secure data environment. And what that will do is streamline and simplify access to data for for various parties across the region.
Mhm.
Initially, it was geared towards academics, academic partners who want to do research around particular areas, as well as clinicians who are research focused. But we feel that there's a lot wider benefits of this, particularly around innovation and improvement to identify challenges, unmet needs, but then also as you're implementing a new improvement or idea or innovation, having access to that data to evaluate it is really valuable. So um, so we are looking at doing some potential hackathons around
Mhm.
that, and we're still in an early stage. So in the next, I would say within 3 to 4 months, it'll start to take shape, and then we can start to share it more widely on our web
Brilliant.
portal and through our social media channels.
Fantastic. No, that's great. Brilliant. Thank you, Ajaz. Any other questions for Ajaz at all? Can't see any others in the chat. We've got many thank yous for you though, Ajaz.
Thank you. Pleasure. It's really great to
um,
connect with you, and I'd love to actually come back and
Yeah.
be a fly on the wall, and
Yeah,
listen
more than
in.
welcome, Aejaz. Yeah, please come along to the future sessions. And
Yeah.
it'll be great when that interactive map that you've spoken about is put together, because there's so much out there, so much,
Yeah.
great resources. So to be able to kind of navigate that will be brilliant. So yeah, thank you
Yeah.
so much,
And I
Aejaz.
think this community, this group, this network is also I see as a key partner in identifying unmet needs,
Mhm.
and creating that process that we need to develop to prioritize unmet needs and challenges across the system as a whole, and document them, for our leadership.
Brilliant, lovely. Thank you so much, Aejaz. That was
Thank you.
great. I will now hand over to Jonny.
Good morning, all. Thank you very much, and thanks again, Aejaz. Yeah, it's very interesting to understand how it works at that higher system and research level. Good morning. Thank you for everybody for coming. My name is Jonny Flannagan. I'm a transformational program manager with the Trust Innovation Group, which is the CNTW, almost a consultancy arm looking at program management, quality improvement. We get various portfolios of work all around the country doing quality improvement and sometimes entire system transformation and redesign, based on various drivers, be that a national driver that's come in via a long-term plan, or perhaps it's come about by a serious incident. So as such, we've got a team made up of what we like to badge as quality improvement specialists, with that backup of program and project support that's needed. So ongoing, I'm just going to move you all across to the screen in case it looks like I'm looking in a different direction. Ongoing, myself and Ashley and other members of CLIC have talked about how we help empower people within the system at the frontline level to get involved in their own change, to own their own change, to be empowered, to realise that they can make a difference. I think traditionally the NHS, and those of us who've been relatively long-term folks within it will know that we've been engaged in many a thing over the year, but you feel like your voice is lost, it doesn't come to fruition, or you're sometimes shown how to do things, but then barriers are put in place to stop you from doing them, whatever that barrier may be. So as part of the improvement network, we're looking to put in a subgroup, a QI group, where we'd love to bring as many of you together as possible who work frontline, who are keen to make change, who, because you work frontline, have identified what those changes are. You know what needs to be done, but you need that support function and that upskilling to be able to know how to bring that change about, and who in your organization can support that change. So that's where this idea of this quality improvement subgroup has come about, which I am leading. I think we've got our first date in for later in the month, but we'll come to that very soon. So I've just got a few slides I would like to take you through about kind of how we'd like to structure that subgroup meeting. Some of the elements we'd like to have in every week, what we would like to upskill people in, what we would like to link up as a wider system, across North Cumbria and beyond, to sort of help implement these changes, make people realise that they can actually have impacts on their own working processes and environments. So just going to slide my teams to one side, and I'm going to share my screen. So if somebody can let me know when they can see that.
Yeah, we got it, Jonny.
Oh, we're getting nods. Great. Okay, I'll be going through the slides. I will be limited as what I can see on the screen. If anybody has got a question, you could pop a hand up, but I don't think I'll see it. So if you just want to pitch in, shout, ask a question, give your own experiences. I like these sessions to be very much user focused. I would like to hear the opinions, the thoughts, the experience, the memories of yourselves through work in such instances. So this subgroup, those of you who have worked in quality improvement have probably heard some of the following through the years. I'm too busy to change how I work. I'm too busy to make things easier, is effectively what they're trying to say. No one's interested in my thoughts. Again, that comes to that, you've been engaged with, you've been asked your opinion, but then you almost feel like it's discarded, and the trust or the service or the organization you work for seems to go in a totally different direction, and you just end up thinking, what was the point in that? I haven't got the power to change anything, because traditionally a lot of organizations, a lot of NHS setups were very top down in the decision making. That would come from a very small group of individuals at the very top of the organizational structure. I can't get my words out today, sorry. Who would make decisions on how that service would be developed and led ongoing. However, because these people have been building towards getting to the top of that organizational structure, it's so long since they worked at the coalface that they're actually quite detached from what is needed. What are those unmet needs, as Aejaz said? What are the drivers? What are people needing that they're not getting? change will always affect me in negative ways. We know this. As soon as we try to do any kind of change with any team, be it system level, team level, individual level, the very first things people will get is that fear of change. Is my job going to get harder? Am I going to be made redundant? Am I going to be moved base? So now I've got a 2-hour commute, and all of those thoughts that are perfectly rational for people to have. It's that almost grief curve when you bring change in. The people they try to embrace it, but then they start thinking of the downsides, and without subconsciously being aware of it, they become resistant to change. And it's about breaking down some of those barriers and helping people understand change before we actually start going into what that change could be. And again, the old classic is we've been asked our opinions and ideas before. Nothing came of it. What's the point? Why should I get involved again? And some of us sitting in this virtual room now have probably got some of those thoughts in our head. Oh, we've done something like this. We've done this. What's the point? We did a year's worth of work, and then the trust just decided we're going to do this instead, and it was all discarded and ripped up and so on and so on. So these QI subgroup we're going to be doing ongoing is all about helping people recognise their part in the system. The NHS is a very, very complex system. Change can be done at multiple levels, both from individual to team to service to departmental to entire areas and regions of the country where we need to be co-producing with not just say other NHS services, but local authority, the research teams and things like that. Everybody needs to be singing from the same hymn sheet. So a graphic we use to kind of explain how that complexity of the system has come in is, and I'm a big fan of this, and apologies, I won't leave it on the screen too long because it does seem to have a hypnotic effect. But basically, I see that as the healthcare and welfare system that we all work in. I'm reliably informed that the blue ball does make its way all the way around, and everyone is attached. And each one of those little machines doing its own little thing is one of us, is the individuals we work with who are frightened of change, and they're all frightened that you move their machine, or you make their machine more difficult to use, or you take their machine out of the system altogether. And all of those things can work to really disempower people from change and being part of change. So that's what we're trying to reverse as part of this group and show what their part is in the system. So when we talk about that top-down traditional approach of how changes were made, decisions were made, and so on and so on, that is kind of the organizational structure of any organization, of any partner provider, of any trust. And quite often, like I say, the the executive boards back in the olden days will say it isn't like that now, but those decisions would get made at the top and it would be trickled down. By the time it got to you, you've heard it fourth hand about how things are going to be, and it's all a little bit lost about what we're actually doing, and it makes it more difficult to implement. A bottom-up approach is where you, the frontline staff, the service users, the carers, the families, the people who we do this service for as well, are empowered to own the change ongoing and understand how you make an impact on your services. So, we've got that there. The individual will have all of their own agendas and thoughts, which is absolutely fine, but we can take all of those upwards and upwards and upwards, just make as many of them as relevant as possible to making a better overall system. So when we talk about the individual, you as project teams, clinicians, admins, service users, change facilitators, whatever you badge yourself as, what does this you mean? What can you bring to the table? And it's again how we empower our teams to help them understand of the changes they can make, what they bring to the table. Because again, going back to the speech bubbles in the first slide, so many of them have had that negative experience where they just think, what's the point? Why? What can we bring to the table which is simply not listened to? So a new way of doing things, a new world of doing things. How can they change that? So that you brings a lot of things to the table. Something that coal face staff and service users bring to it is experience and knowledge. You've either worked in this service or you've been through this service, and you understand what doesn't work. You understand what does work. You understand what's needed more of and what's needed less of, and that's absolutely essential because nobody else in that whole structure can bring that to the table. You bring a realism, and sometimes when you have design workshops, forums, etc., networks like we're having now, sometimes you get somebody in who many of the group might think, oh, they're a bit negative. They're still going back to that, oh, that won't work because, but they also bring a feeling of realism to it as well. You also need to know what are the barriers to delivering this as well. It's not all milk and honey. There is still going to be barriers, even if we co-produce, that realism, that bringing us back down to earth of, well, we've tried that and we got told X, Y, and Z. It helps us pre-plan for what those barriers could be and maybe find a way of working around them. Those frontline folks also understand the service needs and the needs of the service users and carers and families and the people who we're doing this for at the end of the day. They understand what those outcomes are that are needed and how we need to change those and shape those to better suit an ever-changing population. They are able to cascade new skills to a wider team. You'll find out that many teams and many services have a whole huge spectrum, a plethora of skills within them. But the problem of the way we've been working and drilling down to just looking what's in front of us means there's a lot of silo working going on, and we don't actually understand sometimes what people in our own team do and what their skills are. And by bringing that to a forum and saying this is what we're capable of as a team, it allows teams and services and even cross-organizational working to cascade these skills and help us all understand something different a little bit better. Empowerment's a huge one. Again, going back to the speech bubbles, we've all been battened down for so many years. What's the point? My voice has been heard, nothing came of it. They changed their mind, they discarded what I thought. When we're doing any kind of change work, I think it's very important to identify our quick hits along the way. If we find something that isn't necessarily a whole system world changing thing, but it's a quick hit that makes the whole process a little bit easier, just something that either makes a better outcome, saves time, gives us more clinical time back, whatever it may be, you implement them as quick as possible. And when those people who are coming along to these change practices and these design workshops, when their ideas are being implemented as quick as we can, that empowerment starts to build, and you'll find that they'll go back to their teams with a bit more positivity and say, I came up with X, Y, and Z, and they've actually made this happen. That's empowerment. And empowerment can be infectious and can start to spread just as much as non-empowerment can. So again, it's about balancing that and continuing to implement what we say we're going to do. The front line are in the position to change. Again, when there were the days of old when it was top down, and by the time the change had trickled down to the front line, sometimes not always communicated well, some people will be resistant to change. I'm not doing that. That doesn't work. I'm just not going to do it. And before you know it, you've got 3 or 4 different processes going on because some have adopted it, some haven't. And the more variation you have in a process, the more waste and the more errors you're going to create. So when you empower those staff and you get them involved and they are now owning their own changes to processes, they are then in the position to implement that change and really make it work. And the last one I've put on there is to build on and share good practice. We're not always looking to reinvent the wheel. If something's been done really well elsewhere, let's make it work for our area. Quite often you've got local variations. It means you can't always pinch an entire system or an entire team change and just drop it into your team. It tends to work on what we call an 80-20 basis, where 80% of something, you take a similar team across the whole country doing a similar process, 80% of what they do will be the same, but 20% will be very different based on geography, demographics, prevalences of what the health inequalities are in the area. But understanding that 20% is where some of this work comes in and what we're going to try and upskill people and teach them as part of this subgroup ongoing. Is there any questions on that so far? I'll apologise if I do speak too fast. There are some of my former colleagues in the room who are used with my northeast tones. I'm not a Geordie, for those who want to try and say that, so let's get that one straight right now. But if we have no questions, I'll crack on. So a couple of the principles that we work towards when we're doing any kind of change, 2 of the big ones for me. One is the implementation of co-production ongoing. And again, these sessions, these subgroups will really drill down into what true co-production is. Sometimes trusts and organisations badge things as co-production, but it's actually not. It feels more like consultation. It feels like you've been brought into a room and you've been told how things are going to be. Just because you've told everybody in the system how things are going to be, that isn't co-production. The other things we're going to look at is lean methodologies and how you start to implement QI, how you look for what those changes are that improve processes and empower people, and how you make a better outcome. So when we talk about co-production and how it links in with quality improvement, if you have a healthcare system, then you need all of the relevant people at the table, all the relevant parties at the table. Apologies if there's anybody in the room who represents an organisation who I haven't listed there. This is purely just for visualisation purposes. But if we are looking at, say, I'll give an example of a one we've commonly worked in, children's services in a region of the country, you would need all of those sectors and organisations around the table. You would need all of their viewpoints and experience to really understand where we're at now and what we would like to have in the future and how we drag that along. If you take even a handful of those parties away from that table, you get a skewed view. If you took the service users away and the families and the carers away, it's coming very much from a clinical perspective, and what you're going to basically create is a purely clinical process that doesn't take into account how the service user needs that variation and that flexibility of us working towards them. If you take away, say, the voluntary and the third sector and the local authority from that, you take away the social care support function from that, and again, it's very clinical, trying to be flexible to a service user but not knowing what that third sector offer is. And the same is to be said for any of those groups who you take away from some true co-production. you lose the value that they bring to the table in the first instance. So co-production is just that. It needs everybody who's part of a process, anybody who has input or is impacted by the process we're looking to change needs to be involved. We do this in anywhere between 3 to 5 day workshops, looking at individual parts of the system. We do, like I say, either 3 to 5 days. If we do a 5 day, we do a Wednesday, Thursday, Friday, and a Monday, Tuesday, because nobody wants to sit in a room and redesign a service and every detail of it for 5 days in a row. You will literally burn people out mentally. We will then take a break. We will write up what this co-produce group has come back, and we'll come back to them a week or two later in another design event. So they've had time to reflect. They've had time to share the learning with their wider teams and maybe get some more attendees along. And then we start on the next chunk of the system. So if it was children's service, for example, we might do a 3 to 5 day workshop on access. We might do a 3 to 5 day workshop on assessment. The next workshop might be on treatment intervention, and then the next one might be on transitions and discharge. So it's about breaking a service down, but getting everybody around the table to understand every single aspect of that service. And at the very least, what it does, it starts to also break down those silos that everybody works in. And it gives people an understanding of the wider system, so they understand their part. Going back to the blue ball machine, they understand their little machine and why they do it and how that has impact on the rest of the system. Any questions on co-production? Has anybody not heard the term co-production, or has anybody been part of something they believe was labelled as co-production but really wasn't? I can't see hands. If anybody has got one up, please shout up. I know it's quite an early starting session. I'm sure we'll all have a Weetabix. No, we can move on. That's absolutely fine. So the second thing that we talked about is a principle of any kind of change, and something else that we will really go into in this subgroup is lean methodologies. I'm presuming there's a few in the room who've heard of lean methodologies and kind of understand what that is. I'll go through the very basic layman's terms. If not, again, the subgroups will drill down into more aspects of it and give us a few different tools on how we measure and impact on lean methodologies. But basically, lean methodologies, or every process you do, throws up three things. It throws up things that you do that are of value. It throws up things that you do that are non-value, and it throws up things that you do that are just they're waste. They don't need to be done. So if we go through that, if we think of say going to your GP surgery, it's a basic appointment with a GP for a health checkup or whatever it's going to be. The value to you as the service user is sitting in front of your GP or sitting with the nurse and having a physical intervention or going through what your problem is. That's the value part. That's so. Lean methodology says we want to maximize that as much as possible. We want to make as much of the process time value. Non-value is things that have still got to be done, but they don't add direct value to the patient, to the service user's experience. This may be the receptionist booking your appointment. It's essential. It's still got to be done. The admin staff sending out a letter to say this is your appointment. Still essential, still got to be done, but it doesn't add anything to the patient's experience. And then we've got the waste, which is the bit where when you get to the GP surgery, they're running late, so you end up sat there for 45 minutes of your own time. That's time wasted. It might be that there's a problem in the admin process and they sent you the letter 3 times. That's a waste of that admin's time when they could have been doing something productive towards somebody else's process. So they're the very 3 basic things that lean methodologies break every process down into. So rather than a process look like this, it might be sort of 10, 15% value, 25% non-value, and the rest's all waste. The idea of lean methodologies is you try and turn the process into that. You try and eradicate your waste in its entirety if possible. You try and minimize the non-value. So we still do those things that are important to the patient, but we minimize the amount of time it takes to do them. And that leaves all the rest of the time that we deal with that one patient in the process is all value. And you want to see that reverse pyramid coming about from any process. I'm trying not to make this too much terminology based, and the sessions won't be terminology based. We will put everything into layman's terms. So they're the lean principles. So co-production, we all work together. We use these lean principles to try and make a process more efficient, both for the staff, for the organisation, and more importantly for the service users, carers, and families. But how do we bring that lean methodology in? What do we actually do to make it come to reality? Apologies, I'm skipping slides all over. So what we'll be doing as part of these groups, I would like in each group to maybe look at one QI tool per session. And they can be a whole range of things. Some of you may be familiar with some or all of these, but there's many different ways we can break down a service, a process, and look for improvements within it. Sometimes that is done, like Aejaz mentioned earlier, at a system level, which is research, where you get a real big picture of what the regional picture is on various things as part of the system. But again, even they're impacted by how we're working at the front line level. So this is how we start to drill down into the front level. So many of them you might be familiar with. Thinking hats is a chap called De Bono came up with a theory about everybody takes on board. If you give the same statement to 6 different people, every single person could take that statement differently. Some might be empaths and really think about how it impacts on people. Some people might be worriers and think how it impacts on them and will fear the change. Some may be logical people who are like, well, I need some data, I need some facts, I need some understanding about how this is going to come about. And some people are creative. Some people will instantly take that statement and think, oh, well, how can we get creative and do this differently and make it work better than anywhere else? That doesn't mean any of those 6 paths of thought are wrong. They are all absolutely necessary. And when you go to co-production, you'll get all of those trains of thought around the table. And when you start pitching in these ideas of how we're going to change it, you'll get a lovely mix of all those different thought patterns who will bounce off each other. Very important to manage it right so it doesn't turn into a conflict. But when everybody's considerate of everybody's thinking patterns, you get some really rich innovations coming out about how we change things. The creative people will be kept in check by the people who are like, oh, but we just need to, think about this first. And it really creates that mix. And it's a very important co-production tool. Fishbone diagrams, there's a few different versions of that. It's basically a version of the 5 whys. We have something that's gone wrong. We drill down. We look at what the different factors are that impact on what goes wrong. And we really drill down and look at every aspect of everything that impacts on a service and see where it went wrong. And by asking the question why 5 times, the theory is that you can drill down to the root cause of pretty much any problem. We have process mapping on there. Those of you who have worked with me know I'm very fond of a process map. I think a current state process map is a great start to understand what's currently not working. And there's some really obvious stuff comes out of that at first glance when you do a current state process map with a team. There's a SIPOC, which not as many have heard of. Probably my old colleagues in Cumbria are probably sick of hearing me on about them back in the day, but I used them quite heavily. And we got a lot of work coming out of the outcomes of SIPOCs about what needs to change. The 6S, sometimes 5S, sometimes 6S, depending on what school of thought you're from, is simply a way of looking at workplace environments and making them more efficient and work smoother, make things easier to find, cut down on clinical time wasted, and so on and so on. We have after action reports, which is a good way when you're in any large scale piece of change, you stop and stop at roadblocks and you do sense checks, you do after action reports of what have we done so far? Is it working? Do I do the same for the rest of the change that we're still trying to do? And it's that constantly checking yourself, that reevaluation that Aejaz mentioned, even down at very basic level, you evaluate what you've done so far. Another slight take on that is PDSA, Plan, Do, Study, Act. Some of you might be familiar with that. Good for very small scale changes. There is an element of trial and error about it, but if it is some kind of project that's quick and dirty that you can just implement, but you're not quite sure how to do it, a couple of PDSA cycles can quite often get you to where you need to be. And just for understanding, we would like to go through things in this subgroup. It's things like the waste wheel. When we talk about value, non-value, and waste in any process in terms of lean methodologies, we need to really drill down and help people understand what is waste. If I said to you all, if none of you had seen the waste wheel before, and I say to you, what waste's in your workplace? You would look at me blankly. You break those wastes down into categories and explain what those categories are. You'd probably all come up with at least a dozen wastes that occur in your own exact working environment. So it's another tool, it's another methodology of just helping people think differently, which is what a lot of QI is. Anybody got any questions on those? Anybody not familiar with anything? Anybody who feels they would like a little bit more detail on things? There will be the subgroup which will cover all of these. But we do also, both as Click and from Trust Innovation's point of view, we do offer to do any further training, even in one-to-one sessions via Teams. If you would like that, we can come along and work with your team in its own environment and do some QI training or some project management training to understand how we implement quality improvement projects and programs. Any questions, or am I happy to move on? I'm rattling. So yeah, Ashley, you may have some time to kill at the end. Either that or people get an extra cup at the end. No questions? Oh, it's actually popping in there. Yep. Yeah. So Click has a whole plethora of resources on the website. Get them access to some fabulous courses they run as well. If anybody hasn't been on them, I urge them to take a look at them. And again, that offer is extended to Trust Innovation as well, if you want anything specific on maybe project or program management or co-production also. So there is some overlap in what we offer, but have a look on the Click website. So as well as bringing people to this subgroup, at least I hope we bring them to the subgroup, but as well as trying to upskill them and help them understand things like QI tools, things like the lean methodologies, understanding how to bring change in, there's also that element of how they then take that back to their workplace and make changes of their own, raise some kind of change project that simply needs doing. Now, quite often what you may find is people learn these skills, but then they go back to the coal face and suddenly they're lost because they haven't got the support function of how to implement this, and they simply hit a brick wall. If it's a very small piece of change, they could do it themselves. A couple of PDSA cycles, a success on their own ward environment, perhaps, just for an example. But anything bigger where they really need like a bit of data for baselining to be able to reevaluate at the end. Because if you get to the end of a piece of work and you don't know where you started and you can't record what's changed, then nothing's changed, has it? We don't know what we've improved. So when we implement improvement, it starts with the ideas, the innovation, the experiences, the best practices. That's the U level of that structure that we talked about earlier in the session. There also needs to be an understanding of what the drivers of change are. Sometimes those drivers do come from the top boards in NHS telling us here's a long-term plan. These are the things we want you to do in the next 5 years. Some of those drivers will be seeing the whole system of when we come into networks and forums like this and pieces of work come out of it where we do co-produce, where health NHS colleagues are sat with local authority colleagues who are sat with third sector colleagues. Some of the drivers can come out of that of what do we need to do locally? What's our local variations that we talked of that we need to improve? And of course, the co-producing. That co-producing will provide drivers where we go, this is what we need to do in the future. What we add into that is sometimes what can be deemed as the boring bit, but for my fellow project management teams in the room, we won't call it boring. It's an understanding of how we pull change together, how we bring the ideas together, how we document what we've done, how we baseline and do that current state to understand this is how our service works now, and we've identified these things that need doing ongoing. Does a piece of change need some project support? Does it need some documentation like a project plan, a risks and issues log? Does it need a project board? Is it a big enough piece of work where it really needs a project sponsor who's a little bit higher up the organizational structure to remove those barriers for us? Does it need business cases? Is some of this change we're doing going to require some funding? There is pots of money available, and as Aejaz says, there is some piloting pots of money available where we can implement change and really bring some of this to reality, not just the light bulb at the start of it, but really bring a pilot scheme in and say, is this working? What do we need to tweak? And if you've got a program and project support in there, they can help with those business cases. And measuring the change. It's not just baselining at the beginning and then see where you are in a year. It's that measurement ongoing. It's that constant reevaluation of this is what we've done so far, and this is the difference it's made. So if we do a little bit more of it, that difference will be magnified and we'll get more clinical time back and we'll get faster discharges and we'll get reduced waiting times and whatever the piece of work is we're trying to do. And what that should result in, if we get everything lined up right and get all the people on board who need to be, not just those on the front line who have learned the QI tools and implementing them, but our delivery conduits, our project management, our PMO teams, all of those, what we should come out with is better quality outcomes and results. We should have empowered staff who then build on that and want the improvement, not just to be a one-off piece of work, but we want it to be continuous. We want to build on that and do something extra again. What it should do is bring back confidence in the system. I think everybody who has a bad experience with any system, whether that's a hotel on TripAdvisor, a restaurant, or an NHS trust, if somebody has a bad experience, then many of those people are very keen for that bad experience to be heard. And they will share that, and confidence in the system drops as a result of that. If we can start doing, even starting at small projects right up to system level of little changes that reduce the waiting times and all the things that we mentioned earlier, that confidence in the system starts to come back. And that's a big thing for your service user to have confidence in the system. And of course, less waste. So whatever your trust's drivers are, this could be that you are financially running more effectively. Less waste could mean that you don't have as much clinical time, clinicians sitting typing up notes because we've put admin functions in, or technology that means that's done for them so they can see an extra few patients a day. Doesn't sound much for a clinician to see one extra patient a day, but you think how many clinicians we have in our system. If each one of them was seeing just one more patient a day, just one more intervention every day, that's a huge extra patient flow we have on our system. And again, it builds confidence in the system, it empowers the staff, and that continuous improvement keeps rolling basically. So what we'd like these groups to look like, and what we would like people to bring back to them, and it may take 2 or 3 before we start getting some of these stories, but I would like each of these groups to have some kind of presentation of change drivers and practice from senior leads. We've had Aejaz in this one. I'll try and fetch along the QI manager from my own team to say what our trust stance is and how we deliver QI and what our vision is of how we're going to do it. I would then like each session to have some feedback from some ongoing QI projects from yourselves, from the people in your teams, from people within your locality who are trying to do this, and I want their stories to come along. And I don't just want to hear about the successes. I want to hear about the barriers they've hit. I want to hear about something didn't work right. Why didn't it? What more would you have needed to make that work? And really build on those. And when we get that feedback, the offer will be there from both Trust Innovation and from Click to support them from a distance if possible, or even come and like lend advisory skills and say, you could do it differently this time, or you can make it even better by doing this. And it would be nice to have a repository of success stories of QI that's been implemented at the front line that has worked. So other teams and other services within your locality can pick it up and go, actually, we could do that. We could do something similar to this and really get that empowerment going again. Each session would be an introduction to a QI tool. Like we mentioned a few of them there, but there are literally dozens of them. So hopefully we'll have enough to keep us going as a network for a couple of years. And on the back of those, I know within an hour and a half slot in a session, we might only be give a rough overview of what these QI tools were. But again, the extended offer of support is there from both Click and Trust Innovation. Anybody who wants more information or resources or templates to then go and implement this themselves, we are there to do so, and we will support that ongoing. And then maybe round off each session with any questions and to share ideas of the group about potential QI pieces of work that they may have brought to the group wanting to say, or they may have seen the QI tool that we present in the subgroup and think, actually, do you know what we could use that for? And really, let's get creative and bring some ideas to the table. And start to drive and get some QI work rolling and get people realizing that the individual, the you at the bottom of the pyramid really can make a difference. But then also build in what those conduits are to delivering as well. If we can encourage our PMO colleagues to keep coming along as well, because you're absolutely essential. Teams need to be able to come to the PMO function and say, we need the support for this piece of work and this is the difference it will make. That's the kind of ball that trusts need to get rolling. And beyond the meeting, again, I've banged on about so much already, but the offer of support from both organisations is there. It's not just QI offer, it's project and program management. We're not going to necessarily teach you how to be a program manager. Any clinicians or admin or support functions who want to come along, who just want to know a little bit more about project management, who want to be part of a piece of work, they're not going to be the project manager, but who simply need to understand that when there's a project meeting and they get this documentation sent along, what the hell does it mean? What am I looking at? What do I take out of it? What's my part in it? Because project management can be very wordy and terminology based. Is there different ways that project teams can do that? I know on my programs now, yes, I hold a program plan, which has hundreds of lines of tasks on it for different organizations that we're trying to do to redesign community mental health transformation, for example. But what I also do alongside that is I do a slideshow of an update pack. And it simply breaks all the aspects down of what we're doing and just gives a slide on each and says, this is what we've done. This is what we're hoping to do. And if anybody has any input or questions, they can bounce that back to me. We remove all terminology from that. It's in absolute layman's terms. And that update pack gets updated to fortnightly, monthly, however often there's a big change on it, and it just gets cascaded out to all stakeholders on a piece of work, and it makes them feel empowered that they're updated, they know what's going on, they're told what the next dates are for workshops, for meetings, for coming together for ideas, for brainstorming events and all this kind of thing. And again, it's about building that empowerment and keeping people involved. So again, we offer support on that kind of thing. We've got templates that I'm more than happy to show you any of the work I'm doing. There's very little of it top secret. I know my name's Johnny, not James Bond. If you want to see it, I'll talk you through it. I'll tell you some of the pitfalls I've found in doing QI and programs and projects as well. The world isn't perfect, and I'm more than happy to share what those barriers can be as well. And we'll also go through some of those in the subgroup as well. So for the next steps, apologies, Ashley, I think I said I'd do 45 minutes to an hour. I think it's coming in at about 30 or 40. But the first of these subgroup meetings is going to be held on the 28th of this month. We're going to go for an hour initially. We'll review how that goes. People may sit in silence and we may end up watching tumbleweeds blow across the screen. Alternatively, people may come with lots of ideas and it may be a really busy session. So we'll review that ongoing and see how it goes. I urge as many of you as possible to come along to it. We need that input and we need to kickstart a real big quality improvement push in the locality. That real frontline change will really extend into system and like team and system level changes long term. If anybody wants to receive an invite to this, you've probably already got Ash's email address, but it's on the slides there anyway. And any further inquiries or requests or anything you want to ask at all, my email address is on there as well. I will drop Ashley this slide pack and she can cascade it to all members if you've got anything follow up. I'll take that off my screen. Apologies, it means you'll probably see more of me and less of the slide deck. But has anybody got any follow-on questions from that? Has anybody got a real interest, or can they think of anybody within their teams who they think would be good to come along to that and really drive that? Is there any ongoing pieces of work that somebody could maybe bring a story along about things you're doing and tell us about the challenges you've hit, or tell us about the successes? If you've got any of those, it would be fantastic to hear them in that first session. And that's it from me, Ashley.
Struggling
John.
to get my mute button off, but anyway, that worked well. Hiya, John.
Hi there. Hi, Johnny.
Hello, John.
Thanks for that. Really interesting. I'd like to get you to tell me about SIPOC as much as you can over the at least once a year.
Absolutely. It's essential. Everybody should know SIPOC once a year. You're right. You're absolutely right.
Yeah, I think from our team, Ashley, if you could share the invite to all of our team, we will, you know, encourage people to attend. Obviously, it'll be dependent on other commitments, but no, I think it's really important that we share all these tools and know how to use them, and if possible, use them in the work that we do moving forward. So I suppose one thing to sort of mention that, you know, we as a trust, and I'm sure a lot of trusts are facing at the moment, is around discharge. That's one key area that we're doing a lot of work on as a team. And you know, one of the main frustrations at the moment is because of conflicting priorities, because of dealing with the operational pressures. They're the sort of two key elements that really get in the way of the transformation. So it's how we as a team, as a trust, actually try and move forward with those barriers in our way.
And it's about trust and organisations breaking the cycle, John, isn't it? We all say operational pressures, but at which point do we take a step back and say, right, things are going to be more difficult for a short spell of time while we deal with the pressures, but also change how it's going to be in the future. And it's really finding the time to do that can be difficult.
Yeah, I mean, there's a phrase that you'll have heard many times when you're at the trust, we're constantly firefighting. Well, you're not firefighting. Firefighting is something that you do in the short term. What you're doing is the business as usual, and what we've got to do, like you say, is try and break that cycle and do more transformational work, because if you're only dealing with what's in front of you, you'll never change. So,
spot on. Mm-hmm.
Yeah, so that's certainly something that we're feeding back to the trust on, to try and deliver the transformation that I think the trust understands it needs, the willingness to do it, but it's just the capacity to do it is the main barrier.
Absolutely.
Okay.
Well, on the subject of discharge there, John, I know the ICB is running a discharge summit on the 9th of March, I think it is. I don't think the invites have gone out yet, but I'll see if I can get you added to the invite list, John, given obviously great, if that's a key focus area for yourselves at the moment, then you probably want to be part of that.
One of our project managers is working on discharge on patient flow. So I'll forward that invite to Tammy.
Brilliant. Lovely.
Yeah, there's a couple of questions in the chat. Anybody who wants to know anything more, my email's on those slides. Drop me a line. I'm more than happy to give up half an hour, whatever long it takes in the first instance to go through how we do things. I'm not saying how we do things is perfect or the ideal world, but you know, I may use that meeting to pinch some ideas back off you. I'm very open-minded like that. But yeah, that's co-producing, isn't it? So yeah, absolutely. Drop me an email.
It's all about sharing that best practice, isn't it? Definitely. So is there anything that you think we're missing in terms of those kind of subgroup meetings that we're looking to do? Is there anything you guys feel, oh, I'd really like to do X or Y at all? Just making sure that Jonny and I have kind of, thought of the right things.
It would be interesting to see how different individuals, different teams, different organisations deliver their project plans, their project work. I know you've said, Jonny, about what you do. What we do as a team is we've just changed in the last few months where we've standardised the way that we do project plans, and the project plan is set up now so that there is, you know, if it's going to an execs, there is a bird's eye view which gives them a very snapshot picture of what is happening with the project. It's then got a Gantt chart that allows them to drill down into specific areas, you know, whether or not they want to look at any scheme that is off track or any scheme which is due to delivery within the next month or is against a particular action owner, but it allows that drilling down very quickly without going into the detail of the actual project plan, because if you're not careful, you can go into a meeting and go through every line of the project plan and get halfway down and that's the end of the meeting. And then we've also standardized the highlight report, focusing on 4 key areas, you know, what's been achieved this period, what's to do next period, what are the risks, issues and barriers, and what are the things for escalation. But we've, on top of that, we've put it all in one pack with a summary of the key, you know, what the key status is for that particular project and what the escalation is, so that again, if it's going to execs, they're not having to read through, you know, massive reports on each project to find out what the issues are. It's on a 1-pager.
Yeah, we've standardised our highlight report to a 1-page, John. I think you're right. It's a great way of standardising the information, not just for the execs, but again, as part of an update pack for anybody involved in a piece of work, even if they're an admin on a ward, a nurse, a doctor, anybody can just glance at it like, this is what we've done, this is what we're planning to do before we meet again. And that very just basic way of reporting back is really quite key. And I think, yeah, you're right. We've all been in meetings where it's been 2 hours and it's just been somebody reading lines of a program plan, and but I think it's each of those subgroups. I think it's key, as we mentioned, to not just build the QI teams, but understand how organisations, what they've got in terms of support that can deliver in terms of PMO and projects. And I think that's probably a good starting point. Understand how what's our reporting parameters, who do we report to, what do we have to do, can it be simplified? Let's pinch some ideas off each other on that as well. Absolutely.
Yeah.
Lovely. Brill. Thank you, Jonny. That was great. And hopefully, well, I can already see I've had a couple of emails already with people interested in joining. So that's great to see. So yeah, fabulous. Right, I'm just going to pull up my slides again just to do the last one on it, which is just a little bit of signposting, really. So just bear with me, guys, as that's reloading up. Okay, so in terms of what else is out there, obviously, as Jonny has just said, obviously, check out the Trust Innovation Group or get in contact with Jonny because they do have workshops and courses there. We've also got the Aqua program offer as well, and obviously that's where Sarah, who was our last speaker, was from, and I need to pop in, hang on a minute, let me do that now while I remember. There's a link to our improvement network page, so if you want to check out Sarah's session, and also we've got a recording of Jonny from last year who did the SIPOC tool with us, so also feel free to check that out as well and get a bit more information there. In terms of Click's offer, we've got an introduction to managing project session coming up on the 2nd of March. We've also got the Cumbria Improvement System Toolkit coming up on the 9th of March. So that's going through a lot of those tools that Jonny's just gone through there. We've got our OD network as well, where we're looking at high-performing teams, getting to the root cause of conflict. So that's coming up on the 8th of March. We've then got a new session called Productive Team Leader. That's only run for, I think we've had 2 sessions so far, so this will be our 3rd session of it. So that's something new. So if you've got any team leaders looking to work, you know, more effectively, more efficiently, please signpost them to that session. That would be great. And then obviously Jonny spoke a lot a moment ago about co-production, and we've got both our leadership and tools for co-production sessions coming up soon. And then finally, just another date for your diaries. This next Improvement Network session is going to be running on Tuesday, the 25th of April, 10 till 11:30. And we are going to be joined by Gemma Barton from NCIC, who is Head of Quality Improvement and Effectiveness. So hopefully we will get to see a lot of you there. So that's it from me. Is there any final thoughts, comments from anybody at all? No? Lovely. Okay then, well, I get to give you back the gift of time. Thank you so much everybody for attending. Hopefully we will see lots of you at the subgroup at the end of the month, and then if not, hopefully we will see you in April for our next network session. So thank you ever so much for attending, guys, and speak to you soon.